Okay, I think we will go ahead and get started if you're ready. Okay.
Right.
Well, I'd like to welcome everyone today to our webinar. My name is Molly Brown from the Heartland Telehealth Resource Center. We're glad you're joining us today for a webinar as part of our education series focused on telehealth billing, coding, and policy. Just a few notes as we say with every turn. This session is being recorded and we'll share it with you afterwards. Your microphones have been muted, so please unmute yourself or use the chat box to talk. Rochelle's presentations, we have a lot of information, so I will be monitoring the chat box. It's usually easier to use it that way. Your completion certificates will be emailed. It's important to sign on with your first and last name so we can identify you. You can rename yourself by using the 3 dots on your Zoom screen if your full name is not visible. So let's get started. I'd like to introduce Rochelle Martin. Rochelle is a local attorney who's also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursements, HIPAA privacy and security, health information management, and regulatory compliance. We're thrilled to have her today to talk about critical access hospitals, the public health extension implications for telehealth and specialty services within these hospitals. Now I will turn it over to Rochelle so she can get started.
All right, thanks, Molly. So as we're talking about some of the telehealth flexibilities for critical access hospitals, as with all of the sessions that I've been doing for a couple of years now, we're going to have to talk in 3 distinct timeframes, sort of the pre-COVID, the normal rules for telehealth billing for various provider types and focusing on critical access hospitals today. The flexibilities that came about during the federal COVID public health emergency that we're still in, and I'll talk a little bit about kind of projections on what that's going to look like today as well. And then the post public health emergency and what the landscape of telehealth services when the PHE ends, whenever the PHE ends, may look like. And there are some things that we know are going to happen when the public health emergency ends and how long they're going to be in place. And there are some things that are left up in the air, particularly a few impacting critical access hospitals that I'll talk about today. So kind of going to our pre-COVID rules. And when I say pre-COVID, these are also to some extent what may go into effect post-COVID after a lot of flexibilities go away when the federal public health emergency ends. So this is really focused on what have been the long-standing rules for the delivery of telehealth services, absent a lot of these flexibilities that we've had since March of 2020. So our normal telehealth rules involve a series of statutes under the Medicare Social Security Act. And I'm talking about Medicare, but I'll talk about Kansas, Missouri, Oklahoma, and Medicaid programs in just a little bit. But a lot of there are a lot of restrictions normally outside of the COVID federal public health emergency with respect to telehealth. And a lot of private payers and things sort of piggyback on some of those restrictions. So among those restrictions in the statute are a restriction on where the patient is located when a telehealth service is rendered, the types of services that can be delivered via telehealth, the types of distant site professionals who can deliver the telehealth service and bill for telehealth services, and telecommunications technology requirements. Some of these things are restricted in the Social Security Act itself, meaning it's an act passed by Congress. And then some of these definitions and terms are defined by the Department of Health and Human Services as regulations. And the distinction is pretty important. If it is a restriction that's defined by statute, that means when the public health emergency goes away, absent a literal act of Congress to make changes to those rules, we're stuck with what was in effect prior to COVID. But some of these provisions are defined and interpreted and can evolve through regulations from the Department of Health and Human Services. And the advantage of that is that even when the public health emergency ends, there's some flexibility on some of these requirements, and it's within the agency's power to potentially make some changes as long as they stay in line with certain basic parameters under the Social Security Act. So I'm going to walk through a couple of those requirements in our traditional telehealth billing rules for Medicare and point out which ones maybe have some flexibility and which ones are hard and fast rules that we're kind of stuck with absent a change in statute and an act of Congress. And so the first of those is a list of services that are eligible to be provided via telehealth. And this is a list that gets reviewed and updated annually by the Department of Health and Human Services, meaning there's flexibility on this list even after the public health emergency ends. And we know that as we went into the public health emergency, the Department of Health and Human Services added a lot of codes, added a lot of services to this list for the duration of the public health emergency. That flexibility to do that stays in place, stays with the department even when the PHE ends. The only kind of basic parameter that they have to follow is that the services on the telehealth list look and they're similar to physician professional services or consultation services. So there's some very broad parameters under the Social Security Act, but there is quite a bit of flexibility and they do get reviewed on an annual basis. The originating site requirements is a big one that is a restriction normally when we deliver telehealth services under the Medicare program. Before a lot of the COVID public health emergency flexibilities, there were two sort of key originating site restrictions. One, the patient had to be located in a rural geographic area. And there's a really technical definition on what it means to be in a rural area. But one prong of that is they have to be in a rural area. So these were not services that could be provided in, say, the Kansas City metropolitan area or the St. Louis area. Telehealth under the Medicare program, with very few exceptions, has to be delivered to a patient that's located in a rural area and has to be physically located at an eligible originating site. And with very, very few exceptions, that has to be one of these types of healthcare settings. So a physician office, a critical access hospital, et cetera. And again, you see just a few exceptions. The very last one's an important one. The home of the individual was only an eligible originating site where a telehealth service could be delivered in extremely limited circumstances. So we're going to look at how that changed during the PHE and how that may be changing on a permanent basis in just a bit. Those are restrictions in the Social Security Act. So absent a literal act of Congress, we're going to be stuck with those originating sites unless there is a change in the law when the public health emergency ends. The Department of Health and Human Services, the Medicare agency, the CMS agency, doesn't have the flexibility to change those. So then there's a component on the distant site professional. What types of professionals or entities can provide a telehealth service and bill for that distant site telehealth service? Now, these are defined by the agency, by the Department of Health and Human Services and the CMS agencies. So the good news is there's some flexibility there. This typically includes physicians, nurse practitioners. It doesn't typically include therapy disciplines like PT, speech therapy, occupational therapy, or during the public health emergency, any healthcare professional who is authorized to provide telehealth services to Medicare beneficiaries and enrolled in the Medicare program. And the last is the last component of under our normal telehealth billing rules is that it has to be delivered by a telecommunications system. Now, what constitutes a telecommunications system is not defined in the statute. So I think that's good news. That gives the Department of Health and Human Services the flexibility to define what that means. Typically, Health and Human Services defines that to be a live, two-way audio and visual interaction. So just like we're doing here with Zoom, it's live, it's not asynchronous like an email communication is, or portal messaging. A live communication, you could see both parties, and the audio is live two-way feed. So typically that's the definition of a telecommunication system by the agency. And as we know, there have been some extensions or flexibilities to that definition during the public health emergency, where in some cases, audio only communications can be considered a telecommunication system during the public health emergency. Speaking of the public health emergency that we are currently still in at a federal level, even though the state's emergency declaration statuses, at least in Kansas and Missouri and Oklahoma that we're speaking to today, those state emergency orders have gone away in all three of those states. But at a national level, we're still in the COVID-19 public health emergency. So there are a couple of updates there. It renewed in April, and I want to say it was April 19th, if I remember correctly, was the date that it renews, and it renews in 90-day cycles. So when it renewed in April, that extends the federal public health emergency into mid-July. Unless it is revoked sooner, that's the date that the public health emergency would expire, or it could be renewed for another maximum 90-day period. So as of right now, it looks like mid-July is the current expiration of the public health emergency, and that could get extended further. I don't expect an early revocation of that public health emergency status, at least in this 90-day cycle. And I say that because mid last year, I'm losing track of my years now, I can't remember if it was 2020 or 2021, the Department of Health and Human Services that declares this emergency status sent a letter out to the 50 state governors committing to provide 60 days advance notice before revoking or allowing the federal public health emergency to expire. Now, that's not binding. It's possible that it could happen in fewer than 60 days notice, but that gives us a little bit of assurance of how far in advance we would expect to know when that PHE is ending. So giving this presentation today on, what is it? Gosh, the 24th of May already. This has been a really important week, because last week, mid-May, would have been about the time that we would have expected to see 60 days notice if the public health emergency were going to be allowed to expire in mid-July. And as of last night, I haven't seen any indication or notice from the Federal Department of Health and Human Services of its intent to allow the PHE to expire in July. So as of right now, things are sort of signaling that there may be another 90-day renewal coming that would take us into October of 2022 for the public health emergency. And that becomes important for a lot of the flexibilities that we're going to talk about during the PHE and the time frame for several flexibilities afterwards. So now, our current environment in the midst of the federal COVID public health emergency, beginning in March and April and May of 2020, there was, as you all know, just a rapid succession of waivers and flexibilities and policy changes, largely expanding the scope and the reach of telehealth services to make it more accessible throughout the Medicare program and private payer programs and Medicaid programs as well. With respect to those restrictive Medicare requirements that we typically have to follow under the Medicare program, some of the key flexibilities during the public health emergency have been to allow distance site professionals to be paid for telehealth services regardless of the state where the patient was located. So this was a flexibility from Medicare really early on in the PHE. And normally, another one of the restrictions or requirements on Medicare is that distance site professional that's providing a telehealth service has to be licensed in the state where the patient is located. even under the Medicare payment program. And Medicare said, during the PHE, where that requirement kind of goes out the window, and we're going to let providers be paid for telehealth services, regardless of where the patient's located and if that provider is licensed in that state. But I want to emphasize that even though that flexibility for Medicare payment purposes is still in effect, that's a payment rule, and that is not a licensing rule, because many of the states, Kansas, Missouri, and Oklahoma included, their state emergency declarations have expired. Many of the states are again requiring providers to be licensed in that state if a provider is rendering a telehealth service to an individual in that state. So while you could be paid for a service by Medicare, you could also be engaging in the unauthorized practice of medicine or nursing or other professional discipline by not being licensed in that state. So use that, I guess, that flexibility with caution. We did a session a few weeks ago on interstate licensing rules, that if that's something your facility is interested in, or if you're kind of on state borders and you've got patients in multiple states, that may be a good session to go back on the HTRC website and revisit what the current status of various interstate licensing rules are. During the PHE, we also had some flexibilities eliminating those geographic restrictions for telehealth, meaning a patient does not have to be located in a rural geographic area during the COVID PHE in order to receive a telehealth service. So even in those metropolitan areas, Kansas City and St. Louis and Oklahoma City, and others, we can still deliver telehealth services to patients in those non-rural areas and be paid for those telehealth services under the Medicare program. Something that can't happen outside of the public health emergency, because that's a statutory requirement. Health and Human Services can't create regulations to broaden that scope. It has to be a statute, an act of Congress to make that change. And then the other flexibility that we see is adding as an eligible originating site. I'm going to go back 2 slides here. For all patients and all services, the home is an eligible originating site during the public health emergency. So we sort of added that bulleted item to the list. During the COVID PHE, there was also a clarification. So this came about as a result of the rapid use of telehealth, but it's actually a clarification on the rules, regardless of the PHE status before COVID, during COVID, and then after the COVID PHE, that will be in effect, that says telehealth can be rendered incident to a provider's professional service, just like a service face-to-face in person can be rendered incident to. So incident to is a billing concept under the Medicare program. And in the provider office setting and other non-facility, non-institutional settings, a patient can come in and see a physician who creates a plan of care. And let's say that plan of care involves monthly blood pressure checks. And the patient can come back into the physician office, see a nurse, doesn't have to see the physician. Nurse does a blood pressure check, and that visit can be billed incident to the physician's professional service, meaning under the name, under the number of the physician, and paid at the physician's professional rate under the Medicare physician fee schedule. And there's it's not prohibited anywhere, but it also wasn't explicitly permitted that telehealth could be done in the same manner. So that's a really good clarification that we got as a result of the public health emergency, that even after COVID PHE goes away, that's an option for the delivery of telehealth. It also allows one of the rules or restrictions in providing a service incident to a physician or non-physician practitioner's professional service is there has to be what's called a direct level of supervision. And if we were in person in a physician practice setting, direct supervision means in the office suite and immediately available. So if we can provide telehealth incident to the physician's professional service, that concept of being in the office suite and immediately available doesn't really make sense in a telehealth visit. So Medicare clarified that that direct level of supervision can be met through what's called virtual presence. That billing provider, that supervising provider is available and able to immediately join that telehealth session and intervene if there are questions or if there's a need for assistance during the session. And during the PHE, because going back 2 slides again, because the Department of Health and Human Services has the flexibility to define what constitutes down here a telecommunications system, right? That's not defined by the statute, that's defined by the agency. The Department of Health and Human Services allows certain telehealth services to be rendered audio only rather than requiring a video component to the service. Still talking about the flexibilities that we have during the COVID PHE for telehealth. The professionals that are allowed to render a telehealth service can be any professional that's enrolled in the Medicare program and eligible to provide services to Medicare beneficiaries, so long as the location that they are providing their distant site professional services from is within the United States. That requirement to be within the United States, that's a requirement both during and outside of the public health emergency. If the distant site professional is providing a telehealth service from their home, one of the flexibilities that we've got during the PHE is that the home of the healthcare provider doesn't have to be registered with Medicare on the Medicare 855 enrollment forms as a practice location of that distant site professional. So for critical access hospitals who are also now, because you are eligible to you're eligible Medicare providers, critical access hospitals during the PHE can bill telehealth services as distant site providers. So you don't have to change your practice location to do that, where outside of the PHE, that might be a requirement. So CAHs, we are now on the eligible list of distant site telehealth billers during the PHE, where I have seen that primarily come about, and I'll be interested to add to the comments if you have different models where you've used this in your CAHs, is primarily in the outpatient area of critical access hospitals. Therapy services and other outpatient services can be provided to patients who are at home by the critical access hospital. And because the home is now an eligible originating site during the PHE, and because critical access hospitals can temporarily during the PHE provide telehealth services to patients at home and bill as the distant site provider of a telehealth service, it's a whole new delivery model that critical access hospitals can use during the PHE. And there's been an expansion of those services that can be delivered via telehealth, some of which can even be delivered via audio only, and that will extend for a period of time after the public health emergency ends. So now kind of, since we're not out of the federal public health emergency yet, but hoping maybe that there's a renewal in July. Kind of all signs are pointing to maybe another 90-day renewal that would take us into October. But at some point, knock on wood, hopefully the COVID public health emergency will end. So some of those restrictions that are in statute that we're kind of stuck with when the PHE ends, like eligible originating sites, we will revert back to those at that point in time that the public health emergency ends, absent some other legislation. So I do want to point out a couple of pieces of legislation that are out there that do primarily affect or at least in part affect critical access hospitals and their delivery of telehealth. So one of those was called the Telehealth Extension and Evaluation Act. And this legislation was proposed in February of this year. And this particular piece of legislation would extend a lot of these flexibilities that we have during the public health emergency for a period of 2 years after the PHE ends, whenever that is. And among those flexibilities that would have been extended would have included allowing critical access hospitals to provide telehealth services as distant site providers. Because when the PHE ends, unless the Department of Health and Human Services defines critical access hospitals as eligible distant site providers, CAHs can no longer be distant site deliverers of telehealth services. Critical access hospitals will continue to be able to serve as eligible originating sites for telehealth when the PHE ends, regardless of what happens with this legislation. But their ability to bill as distance site telehealth providers would go away. So then a month after that act, that bill was introduced, there was a large 2,000 plus page finance bill, the Consolidated Appropriations Act of 2022. And in this act, a lot of the concepts from the Telehealth Extension and Evaluation Act were incorporated into what was finally passed in March of 2022, extending a lot of those flexibilities, not for 2 years, but for 151 days after the public health emergency ends, whenever that is. Unfortunately, there were some key provisions that were left out of what was finally passed. One of those was this language on controlled substances that can be prescribed via telehealth, absent an initial in-person visit. That was another flexibility during the PHE, and that would have been extended for 2 years under this February bill. But under what actually got passed, that piece was not incorporated. The other piece that was left out that is critical access hospitals, you may have seen and heard about this, is the statutory requirement that critical access hospitals be allowed to continue to bill telehealth services as distant site providers for what was originally proposed as 2 years, what ended up being 151 days after the PHE ends. But critical access hospitals were left out of that provision. So the impact of that is a lot of your, what I have seen as outpatient critical access hospital services delivered to patient as home, goodness, let me try that again. Delivered to patients at home via telehealth, that flexibility will go away, or at least the ability to bill for those services will go away as of right now, the day the public health emergency ends. So that might be July. It looks like that's going to be October. Goodness, I'm stumbling over my words. October, absent another piece of legislation getting passed, or it could be a rule from the Federal Department of Health and Human Services. So as we look at proposals and fee schedule proposals that are going to be coming out in the next several of months that impact payments beginning October 1st for hospitals and inpatient settings, January 1st for professional services, we'll be looking for that type of language to see if that's something that may go into effect. What also went into effect as part of the Consolidated Appropriations Act that did get passed was an elimination of the originating site requirements, or not elimination, but for a period of 151 days after the PHE ends, telehealth services can be delivered anywhere in the US by certain distant site professionals, which unfortunately would no longer include CAHs after the PHE ends. And it can be any eligible originating site, any geographic area. It does not have to be rural. It can be at home. It could be, but it could also be any other site where the patient's located. So we're not restricted to just physician clinics, critical access hospitals, FQHCs, RHCs, and otherwise eligible originating sites, or the patient's home. It can be anywhere that the patient's located. A library, a grocery store parking lot, a retail clinic would also be eligible originating sites for a period of 151 days after the PHE ends. For right now, though, critical access hospitals during the PHE can continue to deliver telehealth services to patients at eligible originating sites, including the patient's home, regardless of whether the location where the patient is a rural geographic area or not. Another thing that we've got during the COVID public health emergency is this concept of hospitals without walls, hospitals operating without walls, which allow hospitals to expand their locations or their departments to also include the patient's home as an eligible outpatient department of the hospital. And so that program includes our regular IPPS hospitals, but also critical access hospitals. So you could make Rochelle Marting's home address a registered outpatient department of the hospital. When that happens and you're providing a telehealth service to the patient at home, then that's no longer the patient's home as an eligible originating site. It is the hospital's outpatient department as an originating site. Professional services, the distant site professional delivering that telehealth service treats it like a hospital outpatient service rather than a service that's provided to a patient at home in those settings. So now we're going to shift gears a little bit and talk about some other pieces of legislation that affect the delivery of telehealth services, specifically for mental and behavioral telehealth services. Before the COVID PHE even happened, so this is kind of talking about regular telehealth rules. There was a piece of legislation passed called the Support Act. And the Support Act extended the reach and the availability to provide telehealth services to individuals who had a diagnosis of some sort of substance use disorder, as well as helping manage mental or behavioral health conditions that co-occur with a substance use disorder. And the telehealth services that could be provided to those qualified individuals who have an SUD, mental or behavioral health conditions co-occurring with a substance use disorder, can, even outside of COVID public health emergency flexibilities, receive a telehealth service in their home and outside of a rural geographic area. So that is a permanent flexibility that will continue even after the PHE ends. The challenge for critical access hospitals is that while CAHs could bill as distant site providers for those substance use disorder and co-occurring mental behavioral health disorder telehealth services during the PHE, CAHs cannot bill as a distant site provider at this time once the PHE ends, unless there's a change in policy by DHHS or a piece of legislation that would make that available. There was a second piece of legislation. So that first one was basically the patient had to have a substance use disorder to make that flexibility to receive a telehealth service at home an option. So then in 2020, there was sort of an extension of that, or a part 2 of that legislation that would make those telehealth services to patients at home also available to individuals receiving telehealth for mental or behavioral health conditions, even absent a diagnosis of substance use disorder. One caveat that has been a real challenge in adoption and implementation is that for this part 2, making telehealth available for mental behavioral health conditions to patients at home on a permanent basis, is that it required an in-person evaluation by the provider who would render the telehealth service within 6 months of that first telehealth visit. That is not a requirement that applied under the Support Act for patients receiving a telehealth service at home related to substance use disorder. Absent substance use disorder, a mental or behavioral telehealth service for a patient at home would require an initiating in-person visit 6 months prior to the first telehealth service, or, well, I should say and, not or, every year afterwards. Do want to highlight and emphasize, though, that because we're in the middle of this COVID public health emergency, which makes the home an eligible originating site for all telehealth services, that initial in-person visit requirement and annual in-person visit requirement do not apply right now during the public health emergency, and won't apply for 151 days after the public health emergency ends. So we'll have a session focused on that topic, basically this slide alone, because it is so complicated and nuanced, and have a full hour session to talk about that particular requirement, because I get questions almost every session that we've been doing about that in-person visit requirement and when it applies and when it doesn't apply and when it will start to apply after the public health emergency ends. So there are some other pieces of legislation that are out there that impact that in-person visit requirement. So as of right now, that in-person visit requirement will not go into effect for telehealth services to an individual at home who is having the telehealth visit for mental or behavioral health conditions for 151 days after the public health emergency ends. There is a piece of legislation out there, the Telemental Healthcare Access Act, that would remove the current statutory requirement to have that in-person visit entirely on a permanent basis. Hasn't been passed yet, but that is a proposal that's out there. And obviously those in the mental and behavioral healthcare community are really advocating for that piece of legislation or ones like it to get passed to avoid that in-person visit requirement. So all of that, those are all requirements under the Medicare program for telehealth services before, during, and kind of what looks like may happen after the public health emergency ends. So now I'm going to shift gears a little bit and talk about the different states' rules for telehealth delivery and a few provisions under the state Medicaid programs for telehealth delivery that you may want to be aware of. So starting in Kansas, and in Kansas, we have what's called the Kansas Telemedicine Act. It's been in place for several years, even prior to the COVID public health emergency. And under that act, it says that telemedicine can be used to establish the provider-patient relationship. So you can have a telehealth service with patients, with new patients, and that can be used to establish the provider-patient relationship. In Kansas, the Telemedicine Act creates coverage parity for telehealth services. So what that means is any service that is covered under a benefit plan as when performed in person also has to be covered via telemedicine. But what it doesn't do is establish payment parity, meaning managed care plans and insurance companies could establish different rates of payment when that covered service is delivered in a telehealth format as opposed to an in-person format. Now, the Telemedicine Act in its entirety was challenged back in 2018, actually the December 31st, the night before it was scheduled to go into effect. And it was challenged in court, and a judge said that the portion of the Telemedicine Act that was under review, there was no standing for it until some previous injunctions were resolved. So as of right now, the Telemedicine Act is still in effect in the state of Kansas. So under the Kansas Medicaid program, just like under Medicare, we've had a lot of waivers and expansion of the types of services and the types of providers who can render telehealth to Kansas Medicaid beneficiaries, including the 3 NCO plans under the Kansas Medicaid program with respect to telehealth. Now, even though the state emergency declaration order, I guess, from the governor has expired and has been expired for, gosh, I guess it's been about a year now. Under the Medicaid program, the policies and the policy bulletins making telehealth available more broadly and more flexible are still in effect. And the language in those policies says they're in effect until rescinded. So as far as I can see, under the Kansas Medicaid program, at last check, they have not been rescinded yet. And so those broader telehealth flexibilities under KMAP and under the NCO plans are still in effect as of today. Another thing that has happened in Kansas, we talked about licensure, is that Kansas has a new, under the Board of Healing Arts, an ability for providers to have what's called a telehealth waiver. So it allows providers who have physicians who have a license in good standing in other states to have this telemedicine waiver to be able to provide telemedicine services to patients located in the state of Kansas. And it's sort of an expedited licensing process. So that provider licensed in another state would not, under this telehealth licensing waiver, be able to come into the state of Kansas and see patients in person, and wouldn't be licensed to do that, but could be licensed to provide telemedicine services to patients in the state of Kansas. And we know that under the Medicare program, those services would continue to be paid right now. So crossing state line over into Missouri, Missouri's COVID emergency declaration ended last August. And immediately after that, there was a new emergency declaration for healthcare staffing shortages, which basically took a lot of the telehealth flexibilities that had been in place under the original COVID emergency in Missouri. And rather than falling under the COVID emergency, they were now extended or renewed under this new healthcare staffing emergency declaration. But that emergency staffing declaration in healthcare also was allowed to expire December 31st of 2021. So what we know now in the state of Missouri in terms of what flexibilities are still in effect versus what went away is that a lot of the provisions that had been there will continue to be in effect until CMS approves their revocation. And I don't anticipate that CMS is going to approve revoking some of those flexibilities unless or until the federal PHE goes away. And I could be wrong on that, but that's kind of what I anticipate. So what those flexibilities are in the state of Missouri, just like Kansas, it allows the provider-patient relationship to be established via telehealth. What does go back into effect is it requires full licensure in the state of Missouri to provide telehealth services or non-telehealth services. So that's back into effect as of January 1st, 2022. Allowing services to be delivered by telephone or at alternate sites. That is a flexibility that's going to require CMS approval before it is revoked. And as of today, I don't see any indication that CMS has revoked that flexibility, meaning telehealth can still be delivered in an audio only telephone type modality in the state of Missouri. All right, headed south to Oklahoma. Now in Oklahoma, mid-COVID public health emergency, May of 2021, there was a payment parity law passed for the delivery of telehealth services in the state. And this is not limited to critical access hospitals, and it's not limited to the COVID public health emergency. This was just a regular state law that was passed for the provision of telehealth services in the state, essentially saying that when a service is delivered via telehealth, it has to be paid at the same rate as that service would be paid when it's delivered in person. We've got some definitions. I won't read the definitions to you. You'll have those on the slides as they go out in terms of what is an eligible originating site. One of the good things in Oklahoma is that can be a school. So especially for younger kiddos outside of the Medicare program, but maybe who are covered under the Medicaid program in the state of Oklahoma, can also receive telehealth when they're located in school, and it's not just limited to like a provider's clinic setting. Remote patient monitoring is specifically described as a telemedicine service or a telehealth service in the state of Oklahoma. So remote patient monitoring are things like monitoring blood pressure, monitoring weight, pulse oximetry, and those physiologic parameters are eligible telehealth services also. So in Oklahoma, as part of this, the telehealth laws in the state of Oklahoma, there's a rule that insurers cannot exclude coverage of a service simply because it's provided via telemedicine. So that's similar to what we had in Kansas that I kind of coined, well, I guess I didn't coin the term, I call that coverage parity. And then Oklahoma goes a step further than what Kansas has done and also requires payment parity for those services also. So this is the provision that requires the payment parity in the state of Oklahoma. So not only can insurers not exclude coverage just because it's provided via telehealth, but when it's covered, even in a telehealth modality, it has to be reimbursed on the same basis and at the same, at the same rate as that same service as when it's provided in person, in an in-person format. Let's see, can't require the use of any particular telemed vendors in the state of Oklahoma. So I think what that particular provision is getting at is, let's say a payer, I'll pick on Blue Cross. Let's say Blue Cross has their own telemed vendor or subsidiary company that they've rolled out as part of their insurance plan that Blue Cross plan couldn't require as part of a benefit package that you use their telemed vendor to provide telemedicine services. So this extends regardless of whether you're delivering telemedicine yourself or whether you use an outside vendor to help deliver telemedicine services. So I want to kind of shift back to some of the things that are happening at a federal level for critical access hospitals in particular. And then if we've got any questions or things in the chat that you want to share in the chat session, we can talk about those with respect to CAHs and telehealth as well. There was a study from the Federal Department of Health and Human Services last year that, not surprisingly, found massive increases in the delivery of telehealth that helped make it available during the COVID public health emergency. And that includes the provision of telehealth from critical access hospitals. So it was surprising to the CAH community, and I think to lots of others, that when the Consolidated Appropriations Act was passed this year, extending a lot of the telehealth flexibilities for 151 days after the PHE ends, that critical access hospitals weren't included in that, even though they were part of the original bill in February to be eligible distant site providers for that 151-day period after the PHE ends. I'll add, though, that even when the PHE ends, critical access hospitals are still eligible to serve as originating sites for the delivery of telehealth. That is a permanent rule. That was in place prior to the PHE and will continue to be in place after the PHE. But what is effective for CAHs primarily is their ability to bill as distant site telehealth providers. What that may do is affect kind of the model or contractual arrangements and relationships that allow critical access hospitals to partner with distance site professionals or medical groups or practices that are eligible distance site providers and billers of telehealth services to continue to be able to reach patients who are at home in that 151-day period, but maybe it's just not the CAH that's the primary biller of those services. So at where we stand today, we need an act of Congress to come in and pass a bill that would make critical access hospitals temporarily or hopefully permanently eligible distance site providers of telehealth services, or a rule and regulation from the Federal Department of Health and Human Services that would define critical access hospitals as eligible distance site providers, something that the department can do through its regulatory rulemaking process, even absent a piece of legislation from Congress. So that's where we stand today, and kind of what things look like in the next 90 days, at least, of hopefully public health emergency, a likely additional 90-day renewal, and kind of what happens whenever the PHE ends, whether that's July, October, or later, for critical access hospitals, at least delivering telehealth services under the Medicare program. Fortunately, with our individual states' rules, requirements, and Medicaid programs, a lot of that's going to continue to be in place for critical access hospitals. It's really the Medicare program where there might be some changes. So I'll pause there with a little under 10 minutes left in the session to see if we've got any questions, comments in the chat session.
We did not have any questions coming in via the chat. If anybody does have a question, you feel free to unmute yourself if you'd like to ask Rochelle anything at this time. While you're thinking of the perfect question to ask, I will let you know that I did put some links in the chat box for some resources, including our YouTube channel with those archived webinars that Rochelle mentioned. Also, if you haven't signed up for a newsletter, please visit our website and you can be added to that list. And I also provided our email if you think of something after the webinar that you would like to ask the HTRC or Rochelle. And as mentioned, we will have, let me double check. So on Wednesday, June 15th, because as Rochelle mentioned, we've had so many questions coming in about in-person requirements, the 6-month rule for telebehavioral health visits. We will be focusing on that topic on June 15th. So please keep your eyes open in your email for that information. We will also be having, we haven't settled on a date towards the end of July yet, but that will be a perfect opportunity for us to have a follow-up related to the PHE extensions and what that could mean. So Rochelle will be providing those updates in July. So also, keep your eyes open for that information too. Let me double check.
In July, we usually see a proposed Medicare physician fee schedule in July. So those critical access hospitals, if you have RHCs or FQHCs that you work with as well, we may have some indication on proposed rules that might go into effect January 1st of 2023 by the time we do that July session.
Thank you for that update too. As we have mentioned, we will be sending the materials out following the webinar today, along with your participation certificates. It includes the link to this recording along with Rochelle's slides in PDF form. So we will get those out. Please don't hesitate to email us if you have questions. We do have a busy June coming up, so keep your eyes open in your inbox to see what those sessions are that are coming up. And we will be sending out information on our July session as well.